Order, order. Luke Taylor to move the motion.
I beg to move that this House has considered chronic urinary tract infections. Thank you, Sir Desmond, for letting me hold this important debate. It's a pleasure to serve under your chairship, as always. Today I rise to speak about a horrific condition that has been ignored for much too long. For thousands of Britons, chronic UTIs turn ordinary lives into living nightmares. The pain and permanence of this illness has left thousands suffering on a daily basis. Having heard many of their stories, it is clear to me that what they're living through is nothing short of torture. But this speech is not just about a medical condition. It's about a scandal that highlights the systemic failure to take women's pain seriously in this country. Over the last few months, a brave community of patients have shared their stories with me. Stories of trauma, of suffering, of desperation. I've been utterly heartbroken by what I've been told. The cruelty of this condition is matched only by the cold indifference its sufferers have faced from our healthcare system. It's a national disgrace that thousands of chronic UTI sufferers have been so profoundly let down by modern medicine. Absolutely. Thank you.
I'd like to congratulate the member for securing this really important debate. As a physiotherapist, I understand with chronic UTIs, there are a number of patients that will say to me this will increase their urgency, then leading to incontinence, and the stigma behind incontinence is absolutely disgraceful. And does he understand and agree with me that it's not just a wider strategy that we need when it comes to, looking at UTIs, but looking at the side effects such as people falling, number of fractures that happen because people are rushing to go to the toilet, and how important it is that we're looking at this as a wider strategy instead of just thinking it's a single issue?
Absolutely. I thank the honourable member for her intervention in raising these related issues, which are so important to consider as well. I think I'll come on to talk about the wider challenge of women's health being treated without the importance that it requires. And I understand she's attempting to bring a debate on a similar subject, so I offer her my best of luck in that endeavour. So many of us have already heard of this illness and heard people's stories. I first learned about this illness through my constituent Phoebe. Phoebe has lived with a chronic UTI since she was 3 years old. Now in her mid-20s, she's become a tireless advocate for others suffering in silence. She shows remarkable perseverance and strength, even when the pain she lives with is beyond anything I can describe. Phoebe is here with us today, as well as a number of other sufferers, and it is my absolute privilege to stand in this place to speak for them and every other individual who is enduring this awful condition. At this point, I would ask the Minister if she would meet with me and Phoebe and representatives of other campaign groups to hear their stories of how they have been let down by the system. A chronic UTI isn't just a diagnosis. It is at present a life sentence of torture that eats away at every part of a person's existence. The condition first develops when bacteria from an acute UTI becomes permanently embedded in the lining of the bladder. Left untreated, the infection becomes entrenched, wreaking long-term havoc on the rest of the body. I want to be absolutely clear, chronic UTI should not be confused with a recurrent version of the condition. A patient diagnosed with a recurrent UTI may experience 1 or 2 infections over a 6-month period. Though still serious, patients suffering from a recurrent UTI experience distinctive intervals of relief from their symptoms. Chronic UTI sufferers live in constant and excruciating pain, with the infection never relenting. They are in agony every single day and every single night. Many sufferers have lived with the condition for decades, with the illness at present being incurable. Chronic urinary tract infections can affect anyone at any age. However, they disproportionately affect women. At the UK's only NHS specialist clinic, which I'll come on to later, 95% of patients are women, only 5% are men. Individuals living with a chronic UTI are often forced to urinate more than 20 times an hour. Each time they use the toilet, I've been told it feels like they are passing razor blades through their urethra. Their urine is bloody, their bladders are so tender they struggle to walk, and their bodies are consumed by fever. In many cases, the prolonged infection spreads from the bladder to the kidneys and the bloodstream, causing sepsis with other complications with other organs. I've been told of harrowing accounts of the agony caused by this illness. The pain has been likened to corrosive acid burning through the abdomen, glass shards lodged in the bladder, and the feeling of mice eating away at the sufferer's insides. Some liken it to scorching knives slashing forever at your stomach, or a hot cauldron constantly bubbling in your groin. But the most common comparison I hear people say is their bodies are perpetually on fire. To reiterate, this torment never stops. For the majority of patients, it is 24/7. These symptoms destroy lives overnight. The illness renders individuals severely disabled, often forced to live a life of bed-bound isolation. The pain is so overwhelming that patients can lose their ability to sleep and become trapped in a cycle of exhaustion. Household chores become impossible, and individuals can lose the ability to care for their children. Sufferers often lose their dream careers as they cannot function with their symptoms in the workplace. They are unable to work or afford costly bills for private medicine. Young adults living with the condition often have to forego university studies, with the severity of their agony making their education unbearable. Romantic relationships break down, with at least one case, marriages of over 40 years ending due to the illness. Sexual intercourse is virtually impossible due to the immense pain. Many people with the condition fear they will never be able to start a family. Patients face an utter loss of independence. And unsurprisingly, depression and suicidal ideation are daily struggles for the chronic UTI patient community. This brings me on to my second ask for the Minister. Every healthcare professional in the UK properly must be briefed to recognise and treat a chronic UTI. Since 2022, the NHS website has formally recognised the existence of chronic UTIs, yet I've heard that many GPs and urologists still deny the existence of the illness. Patients suffering from chronic UTIs are left to fight for recognition, misdiagnosed with conditions like internal cystitis or recurrent UTIs. Absolutely. Thank you.
Thank you, Sir Desmond, for your chairmanship, and thank the member for giving way. Would the member agree with me that part of the issue with UTIs is the use of antibiotics, and that antibiotics are becoming immune to treating UTIs, and the medical profession can't keep up with treatments? And there's a case for better education within the general public in terms of sanitisation. And I know you can get UTIs from different ways, but certainly sanitation would be a helpful education reminder for the local population.
I thank the honourable member for his intervention, and he's absolutely right. Many of our modern medicine practices are designed around avoiding antibiotic resistance from building up, and the intention is to allow high-dose effective antibiotics to be available when required. Yet so many sufferers tell us that when they go to the doctor and require these high-dose effective antibiotics, they're then denied them. And if this is not one of the examples of where these effective antibiotics must be used, for which resistance must be avoided, there cannot be a better example of the mismatch between intention and practice. And I'll come on to it in more detail. But I thank the member for making the point there. None of the diagnoses fit, whether they are internal cystitis or recurrent UTIs, as is often misdiagnosed, and they therefore do not lead to effective treatment. And they compound the sufferer's agonising pain with awful frustration. At their most vulnerable and weak, they're being forced to try to prove what is happening to them is real. That is Kafkaesque. It is totally wrong. The key problem here appears to be that specific NICE guidelines do not exist for chronic UTIs in England, and that SIGN guidelines do not exist for the condition in Scotland. NICE guidelines for acute and recurrent UTIs exist, but as I've outlined, they are not fit for purpose for this chronic condition. How can GPs and urologists provide and recommend proper care as the first point of contact with the patient when there are no clear clinical guidelines in place? Without these, many medical professionals are practically blind to the condition. They cannot prescribe the right antibiotics to relieve patients' pain because chronic UTIs are not even on their radar. Chronic UTI specialists do exist, They do recognise the condition and they can help treat symptoms. But without proper guidance, patients are blocked by their GPs and urologists, unintentionally or not, from reaching them as their request for referral is refused. Many chronic UTI sufferers now have PTSD from their interactions with medical professionals, never mind the suffering from the condition itself. I've heard stories of patients being essentially gaslit by medical professionals, told the concern is all in their heads, denied antibiotics and given antidepressants instead. Some GPs and urologists have, it seems, dismissed the illness as a woman's problem and told patients just to deal with the pain. That is not medicine, that is misogyny. I therefore urge the Minister to push forward the creation of specific NICE and SIGN guidelines on the chronic UTI condition that are distinctive from recurrent UTIs. This is long overdue and will hopefully bring to an end these kinds of interactions between suffering patients and GPs. But that alone will not be enough. There have to be better treatment options for chronic UTI patients further down the pipeline too. Right now there is just one NHS specialist clinic in the entire country, the Lutz Clinic at Whittington Hospital in London. One clinic for a nationwide illness. The clinic offers fantastic support for patients, but waiting times are too long. We all know that waiting lists are currently far too high across the NHS, and I commend the government for their approach to bringing waiting lists down generally. But for chronic UTI sufferers, forced effectively to compete for the time at one solitary clinic, this effect is even more pronounced. Sufferers are waiting months, even years for help after they're lucky enough to secure a referral in the first place. And even once they get there, hope of relief is still not guaranteed. The Lutz Clinic offers long-term, high-dose antibiotics that can treat the symptoms, but they only bring partial relief, leaving many dragging themselves through life, exhausted, drowsy and still in pain. It is not really living, it is enduring. And worse, they do not work for everyone. Around 30% of patients cannot tolerate them at all. Just imagine the despair of being in that 30%. It would be scandalous enough if it was simply that in desperation, many chronic UTI patients turn to private healthcare, spending thousands of pounds of money they don't have just to access the bare minimum of care. But it is more awful than that. Some are forced to go to even more extreme lengths, choosing risky, experimental procedures just to lessen their suffering. Flying abroad to unlicensed doctors, paying over £30,000 to have their bladders surgically removed. Let me say that again. People are choosing to have their organs ripped out in foreign countries because mainstream healthcare in the UK offers them nothing. For some, these risky surgeries offer relief. For many, the infection is already in their kidneys and they return from the operation bladderless with multiple complications. And it is with these little options left that some sufferers make a choice that should haunt this House, the most extreme choice of all, to take their own life rather than live another day like this. This isn't how people should be living in modern Britain, and that is why we should spare no expense in researching better treatments and, of course, as so many dream, a cure. I'd argue that government has an obligation, no matter the prevailing economic circumstances, to expedite the day that this is a reality. There are promising medical trials already underway in the UK showing real potential to transform how we treat chronic UTIs. These treatments are ready to progress to human trials. The only thing standing in the way is funding. I urge the Minister to look into the roadblocks to getting more funding to these trials and come forward at the earliest possible opportunity with a plan to put conditions that are underdiagnosed and under-prioritised, like chronic UTIs, at the front of their research agenda for this country's biomedical research industry. And I would be happy to put the Minister in touch with some of those who are working at the cutting edge of treatment in this field. I've told the story of chronic UTI sufferers and their longing for relief, a relief that this government can help them seek if they back their cause. But I'd like to remind this House that this exists in a much wider context. That is, the way in which health issues that mainly impact women are consistently neglected and routinely dismissed. We know that women wait longer in A&E. We also know that just 5% of global health research goes towards conditions that exclusively or disproportionately affect women. And despite the fact that 15 to 20% consult doctors for chronic pain, It was only this year that the Royal College of Obstetricians and Gynaecologists introduced an optional training module on chronic pain for trainee doctors. Inquiries like Patterson and Cumberledge have laid bare the systemic failures in how women's health is treated in this country, but implementation and cultural change has lagged far behind their words. I have wondered many things since I first heard the stories of chronic UTI sufferers, but nothing has unsettled me more than the lingering thought, if more men were affected by this disease, we would have had better treatments for this decades ago. And this is an oft-used cliche, but it comes up time and time again. I'm short on time, so I'll simply finish with this. The Minister has heard today about the scale of the unimaginable pain that those with chronic UTIs are experiencing. She's heard about the broken diagnostic system, which stops too many sufferers from getting the help they need. And she's heard about the roadblocks to developing better treatments that are standing in the way of relief. So I simply reiterate my asks. Will they meet with these brave sufferers and myself to hear more about the specific actions that government needs to take to clear these roadblocks? Will they commit to pushing for the NICE guidelines to be brought up to date to reflect the latest understanding of this disease? And will they outline what steps they are taking to combat the wider problem of the neglect of women's health issues? Colleagues, chronic UTI sufferers deserve so much more. Thank you.
The question is that this House has considered chronic urinary tract infections. Dr. Alison Gardner. It would be helpful if members bob, if they want to speak.
Thank you, Sir Desmond, and it's an honour to serve under your chairship. I will just say that I am not well today for the very reason that we are here, and so I may just need to sit down throughout the speech, if that's okay. And I am deeply grateful to deeply grateful for the Honourable Member of Sutton and Cheam for securing this incredibly important debate today. This debate is... Sorry. Thank you.
Mr Chairman, it's a very, very difficult subject to, and those who are suffering from it in particular. I'm going to give an example when I was speaking later on. And one of my staff members has that. But I think we're deeply indebted to the Honourable Gentleman for bringing this forward. And I think it's really important that the personal stories that the Honourable Lady in particular would have in relation to this has given the chance to have the opportunity to do that in a way that will express herself on the importance of the subject matter to her personally, but indeed to all of her constituents.
Dr. Alison Gardner.
Thank you. Yes, this debate is not only important to the thousands of women across the country. Indeed, QTIC say there's about 1.7 million suffering from chronic UTIs. It's also incredibly personal to me. I've suffered from UTIs as a result of menopause for over 10 years and I received a diagnosis of chronic UTI in 2023. I don't think that many people realise just how debilitating and excruciating this can be. At my worst, I really wondered how I could go on. I even changed jobs from a beloved lecturing job to one at NICE because I wanted to change things from within. And it's why I'm an MP now, by the way, where I have tried almost everything. I was even considering, as a final step before the final step, of having my bladder removed. My NHS consultant, although he did diagnose me, he did give me Hiprex, methenamine Hipurate, thank God, because it's life-changing for me. But he finally shrugged his shoulders and said I would just have to live with it. In desperation, I tracked down a specialist who worked in private practice, and how lucky was I that I had the money. Dr. Catriona Anderson, who I quite confidently say saved my life. I don't say that lightly. Chronic UTIs can lead to hospitalisation. I've been twice, and sepsis and death. I've got a long list of all the drugs that I'm on, but I won't read it out to you. I do believe that this is yet another case in point of how women's medical conditions continue to be misunderstood, under-researched and underfunded. To illustrate, there is a belief that UTI infections in men are more serious than in women. Whilst acknowledging that men's physiology, i.e. a longer urethra than in men, and than in women, means they are less likely to get a UTI, the possible presence of an enlarged prostate means they may experience restrictive flows and get UTIs. This is certainly the case in older men, but as such, all men are recommended 7-day courses of antibiotics compared to the 3 courses women get. By the way, there's 3 drugs and 3 antibiotics. Trimethoprim and nitrofurantoin is 2, the top ones, which I'm actually allergic to, so I'm on cefalexin when I need it. Lack of acknowledgement that poorly treated UTIs can lead to bacteria becoming embedded in bladders. A much shorter journey in women, incidentally, means the same diligence afforded to men is not considered for women. Plus, women's immune response to pathogenic bacteria in the bladder is estrogen dependent, so is also age-related. Lack of official recognition for chronic UTIs means women do not get equal treatment to men. And I'm a molecular biologist, and I won't bore you with the different types of receptors in the urethral lining of the bladder. To further illustrate, though, in simpler terms, a campaigner told me how her doctor, who repeatedly prescribed her 3-day antibiotic courses for her chronic UTI, prescribed her husband, on presenting with a UTI for the first time, a month-long course. This would entirely clear the infection, of course, and minimise risk of recurrence. That says it all. And incidentally, chronic prostatitis is recognised by NICE. Whilst for many women, as has been mentioned, approximately 70%, 3 days courses will be sufficient. But for the remaining group, 3 days clears only some bacteria, and these bacteria that are relatively resistant. The bacteria then increases in population and we get recurrence. Repeated short courses essentially sets up a system of natural selection for resistant bacteria. It also means the bacteria then have time to invade the bladder and become embedded, finally leading to chronic UTIs. So patients are stuck in a loop. The useless urine dipstick test, which is no more accurate than a toss of a coin, and the midstream urine test, which is even worse, means infections go undetected. No antibiotics are prescribed as a result until the infection gets so worse, and finally a short course is prescribed, but the infection is still not fully cleared. The loop starts again. The infection then becomes embedded in the bladder wall and chronic UTI develops. And incidentally, short-term antibiotic courses often do not treat chronic UTIs, as dormant populations exist within the bladder wall. Your life revolves desperately trying to convince doctors to prescribe a course you know will work for you. And I'm due to move house to Desmond soon, and I am petrified of having to move GPs so that I start that battle again, trying to convince them to take me seriously. I understand concerns around antibiotic resistance and the medical hesitancy in prescribing longer courses of antibiotics, but the solution is not to minimise antibiotic use, it's to get the diagnosis right, treat thoroughly and recognise the existence of chronic UTI and prevent development of chronic UTI. So I'm concerned by the lack of research and guidelines for diagnosis and treating chronic UTIs, and we could prevent them altogether if we get it right. And I'm particularly excited by the UTI vaccine, not currently available in the UK. Prevention will not only save the NHS countless hours and money, but would save people's lives from living miserable lives. I note in April 2025, the Minister responded in a written question that there are no current plans to train GPs and neurologists on recognising the symptoms of chronic UTIs, and NICE guidelines do not contain current guidance for chronic UTIs. This must change. Too many women are being left in unbearable pain without a proper diagnosis or appropriate medication. And as I said previously, and I'll be very quick, Sir Desmond, you've been very patient with me, about 50% of all antibiotics are prescribed for UTIs. There are thousands of deaths each year from UTIs. 200,000 approximately A&E admissions are due to UTI-related illness. The cost to the NHS as well as to people's lives is huge. This debate is personal for me. It is also personal for the millions living with the pain, frustration and isolation of chronic UTIs. So I ask the Minister whether you would meet with me to discuss, and others and campaigners, to discuss how we can improve diagnostic tools, develop guidance and ensure that people suffering from this condition receive the care they deserve. And I thank you for your indulgence.
Jim Shannon.
Thank you, Mr. Chairman. First of all, a pleasure to serve under your chairship. But can I commend the honourable gentleman for Sutton and team for his presentation of his debate today, and on a subject matter which those of us who like the Honourable Lady has had personal experience of it, or like myself who have had staff members who have had this as well, and those who have family members, and I understand my friend and colleague from North Down has experienced that as well. So it is an opportunity to speak on behalf of sufferers in Strangford and my constituency, and indeed across this great United Kingdom of Great Britain and Northern Ireland. The NHS estimates that some 14 million people in the UK experience some form of urinary incontinence, a figure expected to rise due to an ageing population with often very complex health issues, and that's a fact of life. For those who are of a certain age, and I'm one of them, you'll find that your health issues aren't just one, they're multiples, and that's the nature of age as it takes its toll. Inadequate incontinence care can lead to serious complications, with urinary tract infections amongst the most common and concerning outcomes. NHS data shows there were over 1.8 million hospital admissions involving UTIs between 2018 and 22-23, the majority of which involved patients aged 65 years or older. These admissions include both those directly caused by UTIs and those for other reasons where a UTI was also present. It was also one of the reasons. As a leading cause of emergency admissions, UTIs place substantial strain on NHS resources while diminishing patients' dignity, experiences and their outcome. At the outset of this issue, I wish to highlight that both men and women, as well as children, the Honourable Gentleman from Sutton Chemes referred to a 3-year-old girl, I think it was, in his contribution. So there are children that are affected with chronic UTIs. A member of my staff in my office, and one of our a young girl come to work to me when she was 16. She's been there for a long time, so I must be doing something right, Mr. Chairman. She hasn't left me to go elsewhere where the money's better, and maybe the conditions and the time off's better as well. But I understood her issues from the point of view of the pain, the chronic pain that she had, but also the need to be flexible in times. And in other words, whenever she wasn't well, she obviously needed time off. Now, she attended a brief number of hospital appointments for a chronic UTI, and it was a very, very difficult time. She was on antibiotics for 6 months. I think I actually wondered in my mind, is that possible? But in this case it was, because it was so chronic, and ultimately it cleared, and thankfully as well, just on the 1st of January this year she got married, and so her life is going on in the right direction now, thank goodness for that. This was exacerbated at that time by the difficulty of getting GP appointments and specialist referrals. The chronic pain just seemed to exist forever, even with the help of antibiotics, and eventually at the end of that 6-month period, she's now in much better health. I want to also, if I can, Sir Desmond, mention about what we're doing in Northern Ireland, because obviously any debate I bring here will be part of that. And we have something which is, maybe the Minister will tell me in a few minutes when I tell her what it's about. We'll say, well, we're already doing that, and if you are, that's good. But in Northern Ireland, I was very relieved when Northern Ireland rolled out the Pharmacy First scheme, especially since this scheme covers advice and treatment for uncomplicated urinary tract infections without having to wait for a GP appointment in the local pharmacy. Now, if the Minister tells me that they haven't done it in Ireland yet, then can I say it's another Northern Ireland first? And if the Minister hasn't or is not aware of it, should I say, maybe it might be something to be helpful in this debate that maybe could be done here as well. The pharmacist may test the patient's urine to help determine if a UTI is present. So how does it work? What happens when you go to your local pharmacy in Northern Ireland? In some cases, self-care advice may be all that's necessary. In other words, a bit of advice, a bit of a find out what the symptoms are, explain to the person, and maybe is able to utilise and respond fairly quickly. In some cases, self-care advice may be all, but the community pharmacist is also able to supply the patient with medicines to relieve pain, and if applicable, and in some cases it can be, especially if it's chronic pain, antibiotics. In all cases, women will be advised what to do if their symptoms worsen or do not resolve. The Pharmacy First UTI service means that women can be assessed and treated much sooner without having to wait for a GP appointment. In other words, rather than like that young girl in my office waiting for an appointment sometime for a month or maybe 2 months or 6 weeks, whatever the case may be, not only will patients not need an appointment, but community pharmacies are more likely to be open after normal working hours at weekends and bank holidays. And Newton Ards, in my major town, for instance, there's a number of pharmacies, but they take a turn every weekend for one of them to stay open. So there's always access to a pharmacy in Newton Ards and indeed across other major towns in the province as well. The UTI management service has been expanded to more than 400 community pharmacies this year 24-25, following the positive evaluation of that pilot, which involves some 60 pharmacies, first started in July 2021. So the success of that pilot scheme convinced the HSPSS Health Department in Northern Ireland at the Northern Ireland Assembly to do the same, only do it bigger, because this success story can show we can do more. Between March 22 and April 23, some 3,500 women in Northern Ireland made use of the pilot service. Following assessment, more than 85% were diagnosed with a UTI and received appropriate advice and treatment from the pharmacist. However, while this is positive, the fact of the matter is that for those with chronic UTIs, like the Honourable Lady, for example, today the pharmacy does not cut it, and indeed the GPA can only do so much. So there is different levels of response. What we've done with the community pharmacies in Northern Ireland is an automatic response to those who don't have the chronic UTI but have a urinary infection. But sometimes it's much more complicated. The waiting list for UTIs is long throughout Northern Ireland. The average waiting time for urology appointments varies significantly depending on the specific health and social care trust and the urgency of the case. For example, in the Belfast Health and Social Care Trust area, a red flag case, most urgent, might have an average wait of 9 weeks, which is far too long, by the way. It's over 2 months, while a non-urgent case could wait 76 weeks, and a routine case 180 weeks. I mean, those are quite horrendous waiting times in the Belfast Trust, which are completely unacceptable. It is clear that throughout the United Kingdom of Great Britain and Northern Ireland, there needs to be access to specialised care, to new innovation, to new and modern technology, and new ideals, rather than a 6-month course of antibiotics and a hope for the best. In some cases, men, women and children need more, and this must be provided throughout this United Kingdom. And I look very much forward to the Minister. The Minister always tries to, and we had a debate here last week in Aspen, and the Minister responded on behalf of government and responded very well and very positively, and I'm sure today will be another indication of the Minister's wish to make lives better, and this debate gives her the opportunity to do that. And to help those who have been waiting for so long for an end to their health issue. We can do better, Sir Desmond, and indeed we must. Thank you.
Matt Domain.
Thank you, Sir Desmond. It is an honour to serve under your chairmanship. And I would like also to thank the honourable member for securing this important and emotional debate. I'd like to thank the honourable members also who have made contributions, which is clearly a deeply upsetting subject, and also to the members of the public who have travelled to be in the gallery. Hearing the circumstances of this condition, some of you must have had an incredibly difficult journey to get here, to be here to hear what's going on today. So thank you for your efforts in terms of doing that. Some 2019 research showed that in primary care case studies, reported UTI, 83.3% were women, and that it was most common in women over the age of 65 years of age, which clearly we have been hearing about already today. And in 2023-24, there were 679,399 hospital admissions with a urinary tract infection diagnosis. The point about suicide ideation has been touched upon already, but it's important to note that suicides have happened as a result of suffering from this condition. So it's really imperative that it is taken seriously and we act upon it. Sufferers experience being bedbound, unable to work, unable to sleep, leave the house or socialise, all while experiencing debilitating pain. A constituent of mine in Watford has had to give up her job at a school where she had worked for over 2 decades Now, imagine what that feels like when so much a part of our lives is defined through the careers that we undertake. It's nothing short of tragic. It's impacted her personal life as well, and she had to take remedial action even to attend her own daughter's wedding. So what sufferers want to see is firstly the development of effective pain relief. I think that goes without saying really from contributions that have been made already. That new and speedy treatment options are researched and funded. Thirdly, that accurate testing at a primary care level is able to be introduced. And has been touched on previously as well, a meeting with the relevant minister together with sufferers to fully understand the nature of living with this condition, which can be defined overall, I suppose, by a cure. Thank you.
Thank you, Sir Desmond. It's a pleasure to serve under your chairmanship, and as always, a pleasure to see the Minister in her place. I would also like to thank my honourable friend, the member for Sutton and Cheam, for securing today's debate and for being a real champion for his constituents and the wider population suffering with UTIs. And although I won't mention all of the contributions from this morning, I have to mention the honourable member for Stoke-on-Trent South, who spoke not only passionately, but so well informed and very, very personal. And it is the hardest thing to do, to share a personal story. So I commend her for her bravery this morning. Urinary tract infections are far more common than many realise and far more serious than many assume, and women are 30 times more likely to suffer from a UTI than a man. They are agonising and in some cases can even be fatal. Between 2018 and 2023, there were 1.8 million hospital admissions in England involving UTIs, not to mention the no doubt countless GP appointments. Chronic urinary tract infections, where symptoms do not go away, are a particularly distressing form of this condition, and the honourable member for Sutton and Cheam spoke about patients, sufferers being in a bed-bound isolation, in unbearable pain, preventing their lives from being lived, often stopping them from attending those important family events and moments that should be celebrated, because this condition can be so debilitating for them. The short courses of antibiotics then often fail. Urine tests can come back negative, even when the patient is in clear discomfort. And that's because chronic UTIs can be caused by bacteria entering the lining of the bladder, which is making them much harder to detect and treat. The current diagnostic tools that we have available to us are simply not good enough. Midstream urine cultures, MSUs, are still considered the gold standard for diagnosing acute UTIs, but recent research shows that MSUs miss a wide range of bacteria, and this leaves many sufferers undiagnosed, untreated, and often feeling disbelieved. Now, I think, like most women, I'm very grateful of the fact that I do not suffer from regular UTIs, although I do remember in my younger years the panic as a child when you are in absolute agony. And I can remember, I don't know if this is oversharing, but my mum running in with a milk bottle with cold water to pour on me while I went to the toilet, just to take an element of that pain away while you are a young child experiencing something that you do not understand. And I've also seen the impact of a UTI that can be particularly debilitating for those living with dementia, which is something I experienced with my nana in her final years. She couldn't identify that she was experiencing pain, and so it fell to us as her family to recognise the symptoms. Her carer would test her urine most days as she became so prone to the infections. These can cause sudden and alarming changes in behaviour known as delirium, so it often exhibited confusion, agitation, hallucinations, or sudden withdrawal. She did end up being hospitalised for some severe UTIs in her final months, and her hallucinations were enjoyed quite often by the family. There was one that I remember where she was very cross at me for coming to her hospital late at night with an entire choir and singing to her and waking up the whole ward. This obviously didn't happen, Sir Desmond, but under her delirium, she was absolutely convinced that I had not respected her sleep. These symptoms are often mistaken for the progression of the dementia itself, leading to the underlying UTI going uncured. Social care has a key role to play in UTIs, and only 45% of care workers receive any sort of dementia-specific training. We were incredibly lucky that the carer we had for my nana was dementia-trained and recognised the signs of UTIs before they got too bad. And families are vital in this process, especially when someone cannot advocate for themselves. Or, as the Honourable Member for Sutton and Cheam mentioned, when these patients are so exhausted with having to fight against a system that doesn't believe them, families are so often having to step in and be their advocates. So they cannot do it alone. Too often UTIs are dismissed as short-term or minor, but for many people, particularly those with underlying conditions, they are anything but. So we recognise the NHS's recognition of chronic UTIs as a legitimate condition since 2022, but too many people still suffer in silence or are dismissed, misdiagnosed and left without adequate support. And that's why we are urging the government to explore ways to improve diagnosis, particularly for chronic UTIs. Further research is desperately needed. The Liberal Democrats are calling for a significant expansion of the Medicines and Healthcare Products Regulatory Agency's capacity and for a comprehensive agreement with the European Medicines Agency. We must ensure that new treatments can reach UK patients without delay, especially as we rely, as the Honourable Member for Stoke-on-Trent South said, on 3 different strands of antibiotics to treat UTIs currently. And those that suffer regularly are at risk of developing an antimicrobial resistance, which then makes the treatments more effective. And if they are allergic to certain strands, they are incredibly limited as to the antibiotics they can receive. I'm very interested as well that the member for Stoke-on-Trent South mentioned that there is a UTI vaccine in other countries. Continuity of care is equally important, so we believe everyone with a long-term condition like chronic UTIs should have access to a named GP. This would help build understanding, avoid delays and improve outcomes, especially for those whose symptoms may be dismissed or misunderstood. Lastly, I want to touch on the role of community pharmacies, as my honourable member for Strangford mentioned. The Pharmacy First scheme, which was introduced in England in January last year, has the potential to relieve pressure on GPs and provide quicker treatment for uncomplicated UTIs. But many pharmacies are struggling to meet their consultation targets required to access funding. Ongoing financial and operational pressures are undermining the very service that we need to provide, and in the year to date we have lost the equivalent of 4 community pharmacies a week. So my questions for the Minister are as follows. What steps is her department taking to support community pharmacies in delivering the Pharmacy First service, especially those struggling to meet the increasing consultation targets and ensure that patients with UTIs can access timely, local and effective care? Pharmacy First is also currently only available for those with UTIs between the ages of 16 and 64. Is there any plan to widen that age range? Given the known limitations of current testing methods, can the Minister outline what steps are being taken to ensure better diagnostic tools are made available? Is there any plan to introduce a UTI vaccine? And finally, whether chronic UTIs will be included in the 10-year health plan, and is this still on track to be published in June? Thank you.
Dr. Caroline Johnson.
Thank you, Sir Desmond, and it is a pleasure to serve under your chairmanship. I congratulate the Honourable Member for Sutton and Cheam for a really excellent speech, which really did explain graphically how this condition has such a horrific impact on those who suffer with it. And I congratulate him for securing this important debate to raise awareness. As we've heard today, urinary tract infections are common infections affecting the bladder, kidneys and the tubes connected to them. Anyone can get them, but they are particularly common in women. The NHS estimates that 14 million people in the UK experience some kind of urinary incontinence too, a figure which is expected to rise due to an ageing population. Most urinary tract infections, although they're painful, clear up in a few days and can be treated with antibiotics. The earlier a urinary tract infection is identified, the earlier a patient can receive appropriate treatment, the more they'll be able to manage their condition, maximise their quality of life and reduce the risk of chronic infection. Because for many, UTIs are not a fleeting inconvenience, but they're a chronic, recurrent, life-limiting illness. Short-term antibiotic treatments fail, standard urine tests may not detect infections, and persistent symptoms can severely diminish a patient's quality of life. I hope that this debate will raise awareness of the issue of chronic UTIs, which some patients have said have shaped their whole lives. We know that women are 30 times more likely to get a urinary tract infection than men, and that UTIs are agonising and can occasionally fatal. NHS data shows that over 1.8 million hospital admissions involving UTIs between 2018-19 and 2022-23. UTI rates increase when women reach 45 and are in the perimenopause. Studies suggest that over half of all women will experience a UTI at some point in their lives, with many enduring recurrent infections. There are several physiological and hormonal factors making women more susceptible to UTIs, including that they have a shorter urethra than men. Hormonal fluctuations during menopause lead to a decrease in the projective vaginal flora, making older women more prone to infections. Pregnancy, shifts in hormones and pressure on the bladder also exacerbate vulnerability. The Chronic Urinary Tract Infection Campaign estimates there are up to 1.7 million women who suffer from chronic UTIs. Yet, as we heard, this is a neglected area of research, and indeed, as we've heard, women's conditions in general are not as researched and as treated as they ought to be. The last government did recognise this and recognise the need to target women's health conditions specifically, and launched in 2022 the Women's Health Strategy, which was successful in tackling issues disproportionately affecting women. Will the Minister commit to the continuation of this programme? I want to briefly discuss children, and I should declare that I'm a children's doctor in the NHS. The Honourable Member Sutton and Cheam talked of his constituent who was 3 when symptoms first occurred. And urinary tract infections are common in children, with symptoms varying in severity and treatment requiring different approaches based on the age, sex and each individual patient's condition. There are NICE guidelines for this, which also recommend imaging for children with UTIs, including a DMSA scan and an ultrasound, depending on the condition. Could the Minister say what she has done to assess the number of children being treated for UTIs, the waiting times for scans, and whether there are sufficient radiology staff to both perform and report these procedures within the timeframes that are recommended by NICE? The Government has recently pointed to research being carried out by NHS England, along with industry, to Horizon Scan for new innovations in point-of-care tests for diagnosing UTIs to guide better treatment options. With the impending abolition of NHS England, will this research continue? And if so, who will now be responsible for leading it? In 2023, the Department for Health and Social Care, NHS England and the UK Health Security Agency launched a campaign to raise awareness of UTI symptoms and available NHS treatments. Will the Government continue this initiative to ensure ongoing public awareness of UTIs and prevent hospital admissions? Has the Minister evaluated the campaign's success in improving early detection, reducing hospital admissions and reducing the incidence of chronic UTI? For those suffering from UTIs, the first point of contact with the healthcare system is often their local pharmacy. These services are conveniently located in the heart of many communities, staffed by highly skilled professionals with years of experience under their belts. The previous government, as we heard already, launched the Pharmacy First initiative, a scheme in which community pharmacists can treat women aged 16 to 64 with uncomplicated UTIs, offering rapid treatment and advice. A report from the Company Chemists Association in January 2025 found that nearly a third of all Pharmacy First consultations each week are for urinary tract infections. What assessment has the Minister made of the impact of Pharmacy First for people affected by UTIs and other common conditions? My honourable friend from Farnham and Boredom has called on the Government to provide financial incentives for GPs to work with community pharmacies to support referrals into Pharmacy First. As the spending review draws near, will the Government consider this proposal so more people affected by UTIs can access support from Pharmacy First? At the time of its inception, there were concerns raised about the Pharmacy First initiative concerning the increased risk of antimicrobial resistance and standard antibiotics. Now that it's been running for a year, does the Minister have any assessment of whether this is something we should continue to be concerned about or not? The chronic urinary tract infection campaign estimates that 20 to 30% of patients do not improve with initial antibiotic treatment. What is the government planning to do in terms of research to see what more can be offered to these patients? The Honourable Member for Sutton and Cheam raised the issue of NICE guidance and sign guidance, and I can say as a clinician that NICE and sign guidance are very useful to doctors and other clinicians in helping them to guide their practice. And they're written obviously by experts in their field. I wonder if the Minister can speak on whether she plans to discuss with the people running NICE whether they can ask specialists in this field to come up with some consensus-based, evidence-based guidance on chronic UTI, because I think we've heard today that that could really help support patients who are suffering really very terribly. I want to touch on continence care. Adopting a personal clinician-led approach to product provision can allow users to manage their conditions, leading to improved outcomes for both patients and the wider healthcare system. What steps is the government taking to prioritise patient dignity and outcomes in continence care? The government's also stated that support for those affected by UTIs is currently provided by commissioned by integrated care boards. But we know they're facing reductions of budgets of 50% and that many ICBs are planning to merge over the next 2 years. Can the Minister confirm that the responsibility for supporting those affected by UTIs will remain with ICBs, or does she intend that this function is transferred elsewhere? In closing, Sir Desmond, UTIs can be managed with increased public awareness of its symptoms and treatment, early diagnosis, preventative measures, research and improvement in NHS care. And we've heard how life-changing this could potentially be for many, particularly women. All these factors can reduce the burden of chronic and recurrent infections and ensure every patient receives the care they deserve. I hope the Minister will take all of this into account, because she can then help alleviate the suffering of many, many women and people.
Minister.
Thank you, Sir Desmond. It is an honour to serve under your chairship as ever. Thank you to the Honourable Gentleman, the Member for Sutton and Cheam, for bringing this debate forward. And I'd like to welcome and acknowledge Phoebe and all the others in the gallery. And of course, I will put on record straight away that I will ensure that a meeting takes place with the relevant minister. We're just trying to work out, Sir Desmond, whether that would be me or whether it would be somebody else, but I will ensure that that takes place. I'd also like to recognise the contributions from other members here today. The Honourable Member for Dudley, who's no longer in her place, who always brings her own expertise as a clinician to this discussion and has done much to raise awareness. The Member for North Down, who talked about antibiotics, who's also no longer in his place, and AMR, and I will come to that later, Sir Desmond. The Honourable Member for Strangford and the spokesperson for the Liberal Democrats spoke about Pharmacy First. And just to confirm that Pharmacy First does operate in England and it is designed to ensure that women between the ages of 16 and 64 can get treatment for uncomplicated UTIs. I think it is worth saying that the government currently has no plans to extend those that age group because we would not currently consider pre-16 and post-64 to be necessarily uncomplicated, and would argue that that would necessarily mean a little bit more focus. The Honourable Member for Watford recognised the desperation of many sufferers and highlighted the links to suicide. And before I come on to my speech and to refer to some other issues raised by the front bench spokespeople, could I say my honourable, and if I may say very good friend, the Honourable Member for Stoke-on-Trent South. She and I have been friends for some years, and I know how she suffers, and I recognise her courage, and she is such a powerful voice on this issue, and I'm delighted that she has done what was necessary and worked so hard to get to this place, to be that powerful voice on this issue, and I congratulate her on that. Yeah. UTIs, Mr Chair, are very common, especially for women, but chronic UTIs are much rarer. I say rare, but the charity Chronic Urinary Tract Infection campaign, QTIC, estimates that up to 1.7 million women in the UK may suffer from a chronic UTI. This is a very large number of people living in discomfort, and I commend QTIC for their work in bringing attention to the plight of chronic UTI sufferers. I think it's really important that we make clear the distinction between a UTI, a recurrent UTI, and chronic or persistent UTI. A recurrent urinary tract infection is defined as having 2 or more UTIs within 6 months, or 3 or more UTIs within a year. Sometimes symptoms reappearing after a course of treatment. However, regular treatment can eventually cure these. For a chronic UTI, the symptoms never go away, despite treatment. At most, they might slightly abate. A UTI can impact significantly on someone's quality of life, making it hard to concentrate, sleep, or exercise. For someone with a chronic UTI, the pain and discomfort does not end. The physical and mental struggle is relentless. The contemplation of suicide is not uncommon, as we've discussed, amongst people suffering with chronic UTIs. And they can have a negative impact on both intimate and social relationships and self-esteem. This can be incredibly isolating. A population-based survey in England of women over 16 in 2015 found that 37% of women reported at least one episode of UTI in their lifetime. 29% of women reported more than one episode of UTI, and 3% of women reported a history of recurrent UTI in the past year. Misogyny in health services is an issue that has been discussed in this chamber before, and women's health remains a priority for the government. We've been let down for too long, but we are determined to change that, and women's health will continue to be a major focus as we fundamentally reform the health service and get it delivering for patients once again. We're working with NHS England to take forward our women's health strategy, and we have set out plans to use the independent sector to create to cut gynaecological waiting lists through our investment and reforms, and we will make sure that the NHS can be there for all women when they need it. And we are bringing through those commitments as part of our 10-year health plan. It is vital that people with chronic UTIs receive support and compassion from the NHS in diagnosis and treatment. No one suffering with a chronic UTI should be made to feel ashamed or in any way at fault for their condition. Living with the condition is a struggle enough without having to bear the insensitivity of others. Chronic UTI sufferers merit the same understanding as anyone else with a non-communicable disease. And as stated previously, why some people develop a chronic UTI is not well understood, and neither is how to cure one once it develops. A long-term dose of antibiotics has shown to work in some cases, but it's not consistently replicable and is not a risk-free approach. And then there are the added complications of antibiotic resistance to consider when adopting such a treatment regimen, and I will return to this point. Management of the condition is at the discretion of the responsible clinician based on their specialist training and experience. And patients who remain symptomatic despite investigations and treatment by specialist urological services can be referred onwards to tertiary services. Again, it must be emphasised that all patients with chronic UTIs should be afforded compassion and support as part of their care. And as the Honourable Member that has brought this debate has said, there is no NICE guidance specifically on chronic UTIs. The existing guidance provides advice on pain management and hydration, and the local NHS is expected to have regard to NICE guidance in providing care and advice to patients. HSA, the UK Health Security Agency, has begun work in this area, working alongside NHSE England, primary care and patients to develop resources to support clinicians in managing UTI conditions. At the moment, this is for recurrent UTIs, and we agree that more research is needed. To address this uncertainty, research is being undertaken. Through our National Institute for Health and Care Research, we're supporting work to understand the research gaps on UTIs. This is through a James Linda Lyons priority setting partnership led by Antibiotic Research UK, Bladder Health UK and the Urology Foundation. And this partnership will publish its findings in spring 2026. The department, through the National Institute for Health and Care Research, is funding research to improve the diagnosis and treatment of urinary tract infections, including chronic UTIs. And this research includes development of antimicrobial impregnated catheters to reduce episodes of catheter-associated UTIs, as well as something called the Toucan study, evaluating the rapid point-of-care UTI diagnostic tests in GP surgeries. And recently, the NIHR invested £3.1 million into improving primary care antibiotic prescribing programmes. I want to return to the matter of antimicrobial resistance and why this is an important consideration. The first 5-year National Action Plan for AMR in 2019 set out a comprehensive One Health approach to address AMR, acting across humans, animals, food and the environment. And a further 5-year plan was published in March 2024. The UK Health Security Agency has also been working with colleagues from NHSE, primary care settings and patients to develop resources supporting clinicians through the Target Antibiotics Toolkit. This toolkit training is currently being rolled out in multiple NHSE regions as part of an intervention to improve the management of common infections, including UTIs, in primary care. We need to build on these successes and ensure that antibiotics use is supported by evidence. AMR is a significant health threat, and there are an estimated 7,600 deaths attributable to AMR in the UK in 2019. Sir Desmond, the Lib Dem spokesperson also spoke about dementia and the added complications that this can lead to. Diagnosing UTI can be especially difficult in older people who often present with atypical or non-specific presentations, and it can be difficult to assess lower urinary tract symptoms in older patients due to dementia. In care home settings, the resident may not initially present as acutely unwell. This may include increased lethargy, diminished appetite, reluctance to drink, or just not being their usual self. And there is a tool such as Restore 2, which can support care homes to alert them in a primary care, to alert a primary care clinician that the resident may be unwell and would benefit from an early clinical review. Care home staff encourage residents to keep hydrated. All this can be challenging in residents with dementia, as we know. But the department is funding research into dementia and chronic urinary tract infections via the National Institute for Health and Care Research. The Stop UTI project at the NIHR's Applied Research Collaboration, Wessex, sought to identify effective strategies for preventing and recognising UTIs in care homes, and has done some work on embedding activities into care routines and concluded that a systems-wide approach was necessary. In July 2024, the NIHR published a call for research applications to improve diagnosis of UTIs in older adults, and Stage 2 applications are being considered by the funding committee this month. The Honourable Member, the Lib Dem spokesperson, also talked about, let me get my notes, I've been running around making sure that I try to catch everything, about community pharmacy, the 10-year plan, which will of course cover all conditions and is a strategic overview of how we'll improve the NHS for everybody. And I can confirm that the 10-year health plan is on track to be published next month. The shadow spokesperson talked about research, programmes and guidance, and I think I've referred to most of those things in my speech. If I have not, then I'm more than happy to write to the Honourable Member, the Shadow Minister, after this debate. But she did also touch upon prevention, and UK HSA is working with NHS England to run a targeted campaign around UTI prevention in older adults. This campaign will include messages and materials that can be used to support older adults to adapt behaviours that should reduce the risk of developing a UTI, including messages to suggest talking to clinicians about treatment options if they have recurring UTIs. But in conclusion, Sir Desmond, I want to highlight our work to make a health service fit the future. We hope our focus on the 3 shifts to develop a modern NHS will help to address many of the challenges in navigating the health service with those, for those with long-term conditions, including chronic UTIs. Our shift from hospital to community will help drive more joint working between neighbourhoods in primary care, pharmacies, community health and social care to help people manage their conditions. We will, as I've said, shortly be publishing our 10-year plan for health, which will set out how we will make our NHS fit for the future. I want to thank the Honourable Gentleman once again for bringing this debate forward to raise awareness of this important but often overlooked issue. Thank you.
Luke Taylor to sum up.
Thank you, Sir Desmond. I'd just like to start by thanking the Honourable Member for Dudley for her contribution on the broader health inequalities for women and offer her my best of luck to securing the debate that she seeks. I'd thank the Honourable Member for Strangford for his contribution about particularly the strain on NHS resources that the lack of attention on the condition creates, further compounding the challenges and backlogs we have in the system. Thank the Honourable Member for Watford for his account of the impact on his constituents who had to give up her job and the terrible impact that it has on private lives. Thank my honourable friend, the member for Chichester, particularly talking about the challenges around the issues with the antibiotic regime and the issues with resistance and the complexity with that issue. I do thank the contribution of the honourable member for Sleaford and North Hykeham. Particularly, I think, instructive was the focus on treatment of children, because as we heard, the challenge in stopping a UTI becoming a recurrent UTI, which becomes a chronic UTI, is a real focus for that. And again, the focus on pharmacy first to stop that and how children can be addressed to stop that from becoming an issue in the first place, I think was a particularly insightful point. And again, thank her for giving her a knowledge as a doctor to the debate. I thank the Minister for her confirmation of a meeting with myself and with campaigners to discuss the issues. I do note I didn't think there was a specific answer on how nice and signed guidance would be updated to incorporate, but we can speak on that later, and I apologise if I've missed that. I think I'd really like to focus, however, on the contribution from the member for Stoke-on-Trent South, who spoke so heartbreakingly about her experience of the condition and about how it has driven her into politics. And I really do look forward to working together to try and raise this issue and keep it current and understand how we can help her and the incredibly brave campaigners who brought the case to my attention and really see some action with all of the various streams of action that we can put forward in this place. So again, I thank the Minister for being here to listen to the stories of sufferers and responding to my points. I thank all of the honourable members for taking part in this debate, again, and particularly to the honourable member for Stoke-on-Trent, again, for her bravery. I thank, as well, campaigners like Phoebe here in the gallery, whose strength and resilience has given us a chance in this place to try to take clear actions to give them their hope back. Thank you.
The question is that this House has considered chronic urinary tract infections. As many as are of that opinion say aye. Aye. Of the contrary, no. I think the ayes have it, the ayes have it. Order, order. The sitting is suspended until 11 o'clock or until all the participants in the next debate are here, if earlier. Thank you very much.